Hi class, how are you guys today? So here we go. Let's get our minds right and get ready. We're about to begin another lecture, and today we're going to talk about the miscellaneous effects that affect your EKG. Okay. So here we see our doctor approaching Mr. Banana, and he says, "We are a little concerned about your potassium levels." And that's what we're going to talk about with those miscellaneous effects. Or usually when you talk about miscellaneous effects, you're going to be talking about medications and how they alter your EKG, such as digitalis and your electrolytes. Okay, your calcium, potassium. Those are our main two. So here we see with hyperkalemia, there's a serum potassium concentration greater than 5, indicates hyperkalemia indeed. And with this, you're going to see on your EKG, you're going to see a flattening of your P wave, a wide QRS complex, and one of the most defining things will be a peaked T wave. Okay. Some of the symptoms you may see with a patient that has hyperkalemia will be muscle twitching, they'll be real irritable or anxious, blood pressure low, and then of course the EKG changes that we talked about, which is what we're most concerned with here for this class, okay? They may have abdominal cramping, the dysrhythmias, and diarrhea, okay? And what are those EKGs gonna look like with hyperkalemia? Again, we talked about the flattened P wave, the wide QRS we see here, and the significant thing with the peak T wave. Okay. Again, here's another slide illustrating elevated potassium levels, and this just shows you what your normal strip will look like if that person's potassium is at normal levels. And then as their potassium levels increase, you're going to see increased changes on your EKG. So here we have a patient, and she says, "I've been feeling so tired." Her strip is showing bradycardia. We see here. But now let's look at her strip, and we see her P wave is flat, her QRS is wide, and here she has that significant P wave peak right here. So just says her admission history. Mary was just admitted to the CCU for a cardiac workup. She called her doctor complaining of mild chest pain on and off for about 4 hours. She also complained of feeling unusually tired. Her doctor advised admission to the CCU, and upon her lab, her cardiac workup was done, and it revealed that her potassium level was 6.2, and your normal potassium level should be between 3.5 and 5. Mary will soon learn from her doctor that her problems are not cardiac in nature, per se, but they are being caused by her potassium levels being too high. Okay, so the flip side of hyperkalemia, then it's hypokalemia, in which your potassium level is low. So with hypokalemia, here you're going to see a depressed ST segment. And the significance with it is you're going to have that prominent U wave. So here again, you're still going to have your flattened T wave. Remember, with hyperkalemia, we're going to have that tall spike with the T. And now with hypokalemia, we're introducing that where we're seeing that prominent U wave. So with low potassium, that patient may be, again, very tired, weak. They'll have arrhythmias. Their heart rate will be irregular and probably tachycardic. Okay, and they too will have some gastrointestinal problems, vomiting, nausea, and bloating. Okay, so moving right along. So a medication that specifically affects your EKG reading is digoxin. Digoxin effect on the ECG is not a marker of digoxin toxicity per se. It just merely indicates that that patient is taking digoxin. However, it does alter your EKG. Okay, and this gentleman right here is Salvador Dali's mustache is what they've related the look of the digoxin effect on the EKG. So here we see it kind of looks like an upward check mark. Okay. And here's an illustration of what that looks like on your EKG strip. Okay, so let's look at going in review, talking about our hypo and hyperkalemia. We see here, let's look at our normal patients whose potassium is normal. We see here they have a normal P wave, normal PR interval. Their QRS is normal. They have a nice rounded normal size T wave here. And the U wave is there, but it's real shallow. And most often times you don't even see it on the EKG. Now, if they have hypokalemia, you'll start seeing your changes, okay? Your PR interval is gonna start getting prolonged and flat. I'm sorry, it'll be slightly peaked with your hypokalemia. Your QRS is still looking okay, but then you're gonna have that ST segment depression and then a shallow T wave. But then look here, what's going on with hypokalemia, significantly that U wave is starting to rise. So you'll see the prominent U wave. So with these, you guys, each one has their own little separate thing, that characteristic that's significant about them. So if you just keep those things in mind, it makes it a little easier to identify them. So here we see with hyperkalemia, you have the decreased R wave amplitude, and then you have a wide flat P wave and a prolonged PR interval. Your QRS starts to widen more, and then it jumps up here with this tall peak T wave. Okay. Here's just another illustration of hypokalemia, where you have the flattened inverted T. So you look at our T wave here, whereas with our hyperkalemia, that T is going to be really tall. And here's our tall U wave with hypokalemia, whereas with hyper, we'll see the tall T and the small U. Now, hypercalcemia. So when we think about potassium, we think about bananas. And when we think about calcium, we tend to think about cows and milk. So it says, back with the facts, serum calcium levels greater than 11 milligrams per deciliter are too much. It can be the outcome of hyperparathyroidism, and bone metastasis, or bone cancer, okay, with calcium reabsorption from the breast, the lung, or multiple myeloma. Hypercalcemia causes a loss of excitability in the cell membranes and fatigue, weakness, lethargy, anorexia, nausea, constipation, and kidney stones from the increased calcium salts. So what does that do to the EKG? So your ECG activity may show a shortened QT segments and depressed T waves, bradycardia, and varying degrees of a heart block. And here the little dog says he wants to be a cow when he grows up. And here's just a little slide I threw in. Like I said, you guys, you will not be required to remember all of these things. That's why I'm having you make your little reference sheets, whether it be your index cards or if you're writing them down on paper, okay? Because for you to carry with you to help you remember these things. We all in the healthcare profession have our little, what we call cheat sheets. But now, like I said, you cannot use your cheat sheets to cheat on your exams, okay? But you have them as your reference guide in the clinical setting. And it just keeps you from having to go to those books or something that's already there. You have something real quick on hand that you can just grab and do a self-check to make sure that you're doing the right thing and that you're looking at the right things, okay? So what does hypercalcemia look like on that EKG strip? Here we see our normal QT interval right here, our square. And then look, if we have their potassium levels are too high, it's gonna shorten that area. So here's that QT area. You see how your squares have gotten smaller. Okay. So here's a look at all of them together as a distinguishing factor. Now you may want to just use this card as your reference area if that works for you, okay? So here you see your normal. You normally have your P, QRS, and T. With hypokalemia, you're gonna see that long QU interval, and you have the prominent U wave. Okay. Hyperkalemia, you have the prominent, the peak T waves. With hypocalcemia, you have the long QT prolongation. And then with hypercalcemia, you have the shortened ST segment. And that's all I have for you guys today. So what I want you to do is in your text on page 307, I want you to go through each of these miscellaneous effects and identify those key characteristics about each, and show a picture of your work. And this will be, again, a part of your study guide as well as your reference sheet, okay? And I will see you guys next lecture. Bye-bye.